Jevita, go live.
Okay. Good afternoon, everyone. Welcome back to our live session on Cancer Reach. Cancer Reach is initiated by Dr. Krishnamani to spread awareness about the cancer and help the caregivers and patients to access the right treatment on right time. Thank you once again for joining us today. In our last session, we got an opportunity to learn about lymphoma and leukemia from our esteemed guest, Dr. Krishnamani, and also, as promised, today we will understand bit more about one of the leukemia type, which is CML. I guess doctor will explain us what exactly is CML in our coming session. So Dr. Krishnamani is a esteemed. He has more than 11 years of experience in treating different kind of cancer, especially in leukemia and lymphoma. Dr. Krishnamani is associated with American Oncology of Hyderabad. So without any further delay, let's learn what exactly is CML in this chronic myeloid leukemia awareness month with our Dr. Krishnamani. So without further delay, let's welcome Dr. Krishnamani. Dr. Krishnamani, welcome very much for today's live session.
Thank you. Thank you very much. Welcome all to Cancer Reach, which is an awareness platform. And today, as you said, we are talking about chronic myeloid leukemia, which is a type of blood cancer.
Thank you, doctor. First of all, doctor, I should say that I was literally waiting for this session to understand more about leukemia as you promised in the last session, doctor. So, doctor, without what is exactly is CML?
C is for chronic, M is for myeloid, L is for leukemia. Chronic means the disease has been there for some time. It is not all of a sudden. Myeloid means there are two types of WBC cells which can become cancerous. One is called M myeloid, one is called L lymphoid, and this is a myeloid cell. The myeloid cell is becoming cancerous. Leukemia is blood cancer. So blood cancer, which has been there for some time and which affects the myeloid cell and not the lymphoid cell.
Okay.
That is chronic myeloid leukemia.
Okay. So, doctor, generally for this CML, chronic myeloid leukemia, what are the risk factors associated with it?
See, basically now when you talk about CML, CML is caused due to a mutation.
Okay.
What happens is, or we will talk, what happens is there are two chromosomes, the 9th chromosome and 22nd chromosome. There is a translocation, that is exchange of certain parts from 9 to 22 or vice versa. That forms a particular mutation called BCR-ABL. BCR-ABL. This is the one which is responsible for the process or the cancer.
Okay.
So the primary reason one gets CML is due to a mutation called BCR-ABL, which is due to translocation between 9th and 22nd chromosome.
Okay.
So 30 years back, we never knew why we got CML. Now you clearly know if you have CML, you should have BCR-ABL or you should have 922 translocation.
Okay.
Most cases we see are sporadic. You really don't know the reason. Sometimes it could be, it was seen in atom bomb survivors or nuclear accident people and all that. But for most times, you really don't know what the reason is. But the translocation is 922 leading to BCR-ABL, which causes chronic myeloid leukemia.
So, doctor, as such, even now there is no reason why this mutation is happening. I mean, it has not been identified yet.
See, there are a lot of potential factors which have been explained. The bottom line is you need to have BCR-ABL translocation, BCR-ABL, to cause chronic myeloid leukemia.
Okay. So, doctor, for this CML condition, what are generally a symptom a patient or a common person should be aware of? Signs and symptoms.
Sometimes patients can just go have a blood test and the blood test may show extreme WBC high or extreme leukocytosis, we say. A normal WBC count is 4,000 to 10,000. Somebody can have a WBC count of 80,000, 70,000. And a WBC count with a left shift, we say. That is, all the immature cells are also seen. That is the grandfather WBCs, the great-grandfather WBCs, and the neutrophils, everything. We call it neutrophils, basophils, myelocytes, metamyelocytes, monocytes, etc. Everything is seen. Usually, you don't see all these cells in a person. You only see neutrophils, lymphocytes, and a few eosinophils.
Yes.
When you see myelocytes, metamyelocytes, monocytes, basophils, blast cells, then you're talking about CML. So a high WBC count on a routine checkup with a left shift. We call it left shift. Or sometimes somebody may have constitutional symptoms, fever, low-grade fever, weight loss, loss of appetite. Also, sometimes what happens is the spleen becomes very big in chronic myeloid leukemia. Spleen is on the left side. So when it
Okay.
becomes very big, what happens is it presses on the stomach. So your stomach capacity reduces. So patients present with early satiety, that is, they say we have taken little and we feel full.
Hmm.
So early satiety, constitutional symptoms, pain due to the enlarged spleen on the left side, or a fullness. They say that my stomach is full on the left side,
Okay.
and or sometimes just a plain leukocytosis on a routine checkup.
Okay.
If your disease progresses into the next
Hmm.
phase, this is called CP, chronic phase.
Hmm.
It can progress to accelerated phase or blast crisis phase. That is when the blast cells becomes more in the bone marrow. That
Okay.
time, what happens is your hemoglobin will go down, you'll develop anemia, weakness, fatigue, your platelets will go down, you can develop bleeding, you can develop lymph nodes,
Hmm.
okay? And those are the kind of symptoms. So, but most patients come with either a incidental finding or they come with these kind of constitutional symptoms. You do a blood test, WBC is sky high, it has left shift. Then you are concerned whether it's a CML, you do a peripheral smear. As I said, you see the left shift. This is all done very easily in the lab. Just a small blood test with peripheral smear on the slide. You just run the blood on a slide and see it under the microscope. After this, the job comes. The pathologist will say it looks like CML. Earlier, this was enough some 30 years back, but now you need to document it by doing a
Okay.
peripheral blood flow cytometry,
Hmm.
sorry, peripheral blood cytogenetics, FISH for BCR-ABL, and all
Hmm.
these things.
Okay. So, doctor, like what you have told me, what are the different test signs and symptoms which related to some test to confirm CML? Can you little bit briefly tell step by step on the diagnosis part for the CML?
First, you will do a complete blood picture. You will find a high
Yes.
WBC
Okay.
count. If
Yes.
you are in chronic phase, usually hemoglobin platelets are fine. If you go into accelerated and blast phase, hemoglobin and platelets will come down. In the same CBC, you will see left shift. Neutrophils,
Ah,
lymphocytes, myelocytes, metamyelocytes, monocytes, basophils, etc.
yes.
Then you will do bone marrow.
Okay.
You will send the blood for cytogenetics and FISH for BCR-ABL.
Okay.
Once FISH for BCR-ABL is confirmed, you have
Hmm.
some.
Oh,
Okay. And then you commence the patient on treatment.
okay. So it's like almost you can say, doctor, these are the last step is to confirm CML. So two test.
So the confirming CML is done with the help of your BCR-ABL by FISH or karyotyping for 922.
Okay. So, doctor, like somewhere I heard, what are the basic reasons for pathogenesis in CML, doctor?
So the basic root cause of CML, as I told you, is the 922 translocation.
Yes.
Once you
Yes.
have 922, they form a product called BCR-ABL that drives, that
Okay.
leads to an arrest of cell maturity. So the cells don't become neutrophils. So
Hmm.
all the older cells also are slain.
So, in generally, doctor, only the matured cells are released in the blood as per the requirement of the situation.
You should have neutrophils, you should have lymphocytes. When you have all the other cells, then there's an arrest in the process. That arrest is due to the mutation. You are going to treat
Okay.
by removing the
Hmm.
arrest so that
Oh,
the older cells become normal, newer cells.
okay. So it's quite a challenging step, doctor, to identify. So right now, doctor, what are the treatment options available for CML and what are the different, or you can say types of drugs used for CML? As last time I remember, doctor, only a drug can take care of the
Yeah.
CML.
So CML is the wonder story in oncology. So some 25 years, 30 years back,
Huh?
patients used to progress from CP to AP to blast crisis in 5, 6 years and they used to die. They used to receive toxic medications like interferons. They used to be advised transplant as the only chance of cure.
Survival. Oh my God. Okay.
Now, come the 20th century, 21st century, in 2000, we have been able to find out BCR-ABL. Drugs have been created. The first drug which worked in CML, which was a targeted drug, was a drug by named imatinib or Gleevec.
Hmm.
In fact, it was featured on the Time magazine also
Oh, wow.
because it's a wonder drug. So
Yes.
imatinib is a pill. It's a tablet. We call it a small molecule tyrosine kinase inhibitor. It acts inside the cell, removes the block, attacks the BCR-ABL, and allows the older cells to become mature cells.
Okay.
So it was originally called Gleevec by the original company, and then you have multiple generics now in India. You have almost 100 companies or 50 companies, if I must say. And the cost of a therapy for 1 month is as low as 1,000 to 2,000 rupees.
Oh my God, so economical.
Economical. One tablet a day.
Hmm.
So imatinib is taken. And how long do you take? You keep taking it till you get a response or till the drug is working. Earlier, what used to happen? You used to give interferon, you used to give other medications, you used to give a lot of other chemotherapeutic drugs, oral chemotherapy drugs sometimes, and then patients used to progress. And once they become last phase, you will treat them like an acute leukemia by giving intensive chemotherapy and even think of transplant. Now those days are gone. Then Gleevec came, people started giving Gleevec. Started working beautifully well. Immediately, the spleen will regress, they feel better, appetite increases, everything improves, left shift becomes normal, all the myelomatous disappear.
Okay.
Your blood count becomes completely fine, WBC completely comes down to normal within 1-2 months also. Excellent. Then what they saw is, in a few set of patients, the disease is coming back again, the WBC is increasing again.
Lapse case kind of a thing.
Correct. So then newer drugs came. Drugs by name nilotinib, dasatinib, bosutinib, etc. So they needed the newer drugs to combat imatinib resistant cases. Then what people did, they got these newer drugs in the beginning itself. If they are better than imatinib, why not use in the beginning itself? Why wait till later?
Yes.
So they are also used in the first line setting. Like imatinib, dasatinib, nilotinib is used in first line.
Okay.
Then people also saw, after giving nilotinib, dasatinib also, some people are recurring or relapsing.
Lapse case.
What to do? Then they found out there is a mutation called T315I. It is done on the blood. So if you are T315I positive, imatinib, nilotinib, dasatinib, nothing will work. You have to be put on a drug by name ponatinib.
Okay.
So the first drug was imatinib, then its successors came, which were supposed to be superior to it or given after failure of imatinib. Then they were given along with imatinib itself. Some patients were receiving those drugs as first line. That is called second generation medicines. Imatinib is first generation, like your iPhone first generation.
Yes, yes.
This is the second generation which was started to use in the first line. Then if they fail on either of these, you do T315I analysis. If you're T315I positive, you are given ponatinib. Also, what happened is, earlier we were very happy. I'm talking about 25 years back, maybe. When you started imatinib, if the CBC became okay, patient became okay, everybody was very happy. Then when we started knowing more about the disease, we started realizing that the CBP becoming okay alone is not enough. That is called complete hematological response. You're not just bothered about the surface. You want to go deep inside. So the CBC is just on the surface. So if somebody is developing a complete hematological response, that is hemoglobin, WBC, platelet becoming normal, that alone is not enough. And how quickly is it becoming normal also is important. If you take imatinib and after 1 year you achieve CHR, no. You should attain it within 1 month. And attaining CHR alone is not enough. So people started defining response criteria.
Response criteria.
At 1 month, you should have CHR.
Okay.
At 3 months, you should do BCR-ABL and 100 should become 10. 1 log reduction. At 6 months, 10 should become 1.
Okay.
At 12 months, BCR-ABL should be 0.1 and less. If you achieve this, you have achieved MMR, major molecular remission. That is when the drug is continued. If you fail anywhere here, imatinib is immediately escalated to dasatinib.
Dasatinib, second generation drug, as you said.
So you are not going to wait anymore for the CBC to fail.
Okay.
See, all along CBC and B may be normal, but molecular relapse may already happen before itself. So at 3rd month, if you don't attain BCR-ABL 10, at 6th month 1, At 12th month, 0.1, you are going to change. You're not going to wait till 12th month. At 3rd month itself, suppose your BCR-ABL is 40.
Hmm.
Then you are going to say you should be less than 10, boss. You are 40. That means imatinib is not working. You are taking
Change
the
of
drug,
the.
but you are not working. The medicine is not working. Do T315I. If there
Okay.
is T315I is not there, I will go to dasatinib or nilotinib. If T315I is positive, I will go to ponatinib.
Oh
So
my
the
God.
bottom line is what we should understand is now we have a beautiful drug in imatinib. Close to
Hmm.
20 years data is there on that. Excellent safety record. One tablet at a day at home.
In a day.
Patient do very well. If imatinib fails, you have dasatinib, nilotinib. If that fails, you have ponatinib, and you have monitoring at the very molecular level also. And because of that, what's happening is now there are patients who are taking imatinib for 3 years or dasatinib for 4 or 5 years.
Hmm.
So you want to give them a holiday also. You come to that stage also where you say you have been taking imatinib for 4 or 5 years. You have already achieved major molecular remission for almost 3 years. You are doing extremely well. If needed, we can even give you a break. If you don't relapse, well and good. If you relapse, we will start with you on the same imatinib again. Not to worry. So
Oh.
you have developed the drug, you have developed better drugs, you have developed excellent monitoring, very close monitoring, getting the response, going to the deepest molecular level, not only at the CBC level, and also saying if you have achieved that so good response for so many years, we can even think of stopping the drug for you. So
It's a holiday kind of a thing.
where was transplant? Where was dying in 5 6 years into accelerated or blast crisis? And where is today's this one modern medicine where you are even thinking of stopping that tablet? So
In fact,
that's how far the science has come in CML.
exactly, doctor. Even like just to highlight, the diabetic patient or any BP patient cannot stop the drug. They don't have any vacation kind of a
And what?
period in their treatment.
So the message. So the message here is not that CML patients should stop the drug. I'm just trying to emphasize that there is a school of thought. There are people who do that. It is scientific. That we are also looking at stopping the drug.
Oh.
And what are the side effects? Practically, see, imatinib will cause some fair skin,
Hmm.
face becomes fair, pale, some swelling
Okay.
around the eyes and legs, so on the eyes, sorry,
Hmm.
some body pains. Dasatinib can cause effusion, that is water in the around the lung, fluid around the lung. Nilotinib can cause certain issues, but they're all not life-threatening issues.
Hmm.
So basically, and for the patient is very easy. It's a tablet they take at home. They need not come to hospital, take chemotherapy, take injections, and all these medicines because of generics are so cheap now. It's not an economical burden at all.
In fact, doctor, like if anybody like the cancer, any patient will like any patient or the person, they will think that cancer treatment is very cost effective and the patient has to be hospitalized. They get fear of that. But looking into the modern technology of the treatment, especially for CML, it is like a patient at home only have a tablet and he or she can do his daily work normally as he
They
is
go to
doing.
work, they go to office, they do everything. They have to come every
Yeah,
3 months, do a BCR ABL for the first 1 year, and then every 6 months maybe. And that's it.
that's actually really a technology has given a life to some of the CML patients then, doctor.
Now we have CML patients who are, so we have a patient who was being treated by my teacher. She was diagnosed in 96 when she was maybe 16 years or 18 years old. She was
Oh,
put on all those old medicines. Then the
uh,
imatinib trial started. My teacher had put her on the trial,
okay.
and then she was on the drug. Now she received she was on the drug for 8 to 10 years, then dasatinib for a few years, then nilotinib, and almost nilotinib for 10 years now, and she's doing extremely well. Is in molecular remission.
In 96, doctor, then
96,
now she
24.
will be somewhere around 48, 50 years, if I'm
Yes.
not wrong.
She started at the age of
Wow.
16 years.
Wow.
She's married.
Okay.
She's doing well. She
Wow,
has a
very lucky.
family.
Wow, that's really a great. Where, doctor, initially you told that for CML who were diagnosed far before, only 5 years was the survival rate
Five,
for
six
them.
years.
Now it's like very lucky. That's really a technology wonder, doctor. You rightly said that's a wonder tablet.
So that has paved the way for many other tyrosine kinase inhibitors in many other diseases like renal cancer, in hepatocellular, liver cancer, in sarcomas, in so many other
Okay.
cancers. And the same imatinib is also used in a disease called GIST, gastrointestinal stromal tumors.
Okay.
So that's the beauty. So you find the root cause of a disease, you find that mutation, you target that mutation, you have achieved success.
Technology is really a wonder, doctor. Then, doctor, like, how do you access response in CML, doctor? Like, you are
How we
saying
discussed.
something. Can you brief more on it?
So you at 1 month your blood test should become normal, complete hematological response. And
Yes.
when you do BCR-ABL at 3rd, 6th, and 12th month, and you have certain criteria. If you reach that criteria, you have reached response. If you have not, then you will escalate treatment from imatinib to other agents.
Okay.
All along, our patients should
Uh-huh.
understand that they should be compliant. If you don't take the drug and BCR-ABL is sky high, that means you're not taking the drug. It's not because of the disease. So if a
Yes.
compliant patient is not achieving a response, then you should think of changing the medicine.
Generally, doctor, when with a simple tablet, if a patient can get his life back from CML, then they should never miss a tablet.
No, but sometimes the bone pains can be very severe in our patients, especially in the first
Okay.
1 to 3 months. So because of which some people discontinue, they are in severe pain. They are admitted also sometimes. We give them magnesium and calcium supplements.
Okay.
So the bone pain is sometimes a limiting factor. So you have to educate your patients.
So it's, doctor, like a joint pain kind of a thing. You
You
can.
generally have muscle pains and joint pains, especially in the lower limb, legs.
Okay. So, but doctor, like in the continuation, that symptom can be taken care.
Very much.
That is small symptom, doctor. When compared to CML, this symptom is very less.
Of
Easily it
course,
can be taken care.
when compared to your blood cancer, your bone pains are a temporary phenomena. So try to control that, you'll be fine. That's what you should say.
Yes, yes, very true. So, doctor, like generally in CML patient, what is the prognosis of the patient, and like what should a patient look forward if they have any CML
So
kind of a thing?
don't get disheartened if you have been diagnosed as CML. There are multiple options. Most of them are tablets. There are first generation, second generation TKIs and beyond. We are looking at response criteria. The prognosis is extremely good. We just discussed patients who live for 20 years, 15 years, 25 years now. So it is not what it was many years back. Patients definitely do well.
That's it is really surprising, doctor, where 5 years survival, where the patient, you have a live example who has started his life, enjoying his life, having a family after 45, 50 years. That's really a great. So, doctor, like now also, even after that a long treatment, even there is any cases that the patient are not getting recovered even after the third generation and all those things. Any transplant, they are ending up.
Yes, some patients do end up, right? Some patients, unfortunately, the disease is that bad, they go into an acute leukemia, blast phase, whatever you
Okay.
do. So that
Hmm.
unfortunate set of patients are there, but that number is extremely low. The number is extremely low. Even for T315I resistant disease, you have ponatinib now. So that's a blessing. Ponatinib is started in those patients who have T315I mutations. And
Okay.
the number of patients who develop blast crisis or who would need treatment for acute leukemia is less. It has reduced considerably.
That's really, doctor, a good news to everybody. In fact, it is. That's why, doctor, you told them as a wonder tablet. I will also, after listening to all those things, yes, they are a wonder tablets. Doctor, that was something very interesting on CML, doctor. Unfortunately, the time is coming out, but we are still have so many things to learn about it, if I'm not wrong, doctor.
Correct. So to summarize in a nutshell, what we usually do, what our people should understand is it's a blood cancer. There's nothing to be worried about it. You need a BCR-ABL to prove it, which is done on the blood. People
Hmm.
sometimes do it on the bone marrow also. If you are BCR-ABL positive, you'll be put on imatinib or second generation agents like dasatinib, nilotinib. You are looking for response criteria at first month, third month, 6th month, 12th month. Because if you don't get a response, your medicine is changed very early at third or sixth month itself to the second generation drugs. Patients have to take the drug continuously till they are getting the response. Response assessments later are made every 6 months or once a year. There are a few patients who have an excellent response for many years, and they are even advised whether they can stop the drug, which is called a treatment-free interval or a drug-free interval. Side effects are bearable. Patients do very well. Economical drugs, not to worry. And the landscape has changed so beautifully for these patients. Now there are so many CML support groups in India also. That is, one is called the Gleaver Foundation, where all the CML patients congregate together. They share their experiences. They try to educate each other. They are educated by their doctors, who are also their role models and teachers. So CML has undergone a transformative change.
That's really
The
wow.
patients are going to do well and they will do well.
Sense, doctor. That's really a good news, doctor, for all the CML patients, doctor. Thank you, doctor. Thank you very much for such a wonderful session. I hope anybody who are worried like the blood cancer is really a deadly cancer or the person will have very less time to survive. But no, as doctor rightly said, now the technology has changed a lot and there are so many wonder drugs available which will make a life easy for a CML patient.
Thank you so much. Thank you.
Thank you, doctor. Thank you. And thank you once again for everybody joining this live session. So wishing you all strength, hope, and good health from Cancer Ridge. Thank you, everybody. Thanks a lot.
Thank you, Jivita.
I think the live session stopped down.
1 second. हाँ जीविता